Good evening, everyone. A very welcome from Malaysia. I'm Dr. Hakian On, the moderator of this evening's Osstem webinar. It is an honor for me to host this Osstem Malaysia's webinar. And this evening, we are very fortunate to have Professor David Niao as the speaker. And for Malaysians, Prof. Niao doesn't need any introductions for the benefits of others that is outside Malaysia. So I would read a lengthy of his CV. Professor David Niao is currently a professor at the Department of Oral and Maxillofacial Clinical Science, Faculty of Dentistry of UNIS Malaya. He graduated from the University of Malaya in 1992 and was in the private practice for about 9 months before he actually offered a post of tutorship in the University of Malaya. And 3 years later, he became the senior house officer at the Queen's Victoria Hospital in East Grinstead, England, where he obtained his fellowship in dental surgery from the Royal College of Surgeons in Ireland and Royal College of England. He subsequently returned to Malaysia and was the pioneer lecturer at the then newly established National University of Malaysia. He later became the lecturer of University Malaysia in the year 2000. He has published more than 180 papers in local and international journals. In 2005, he was the editor of the Malaysia Dental Journal from 2005 to 2007 and the editor of the MDA Malaysia Dental Association newsletter for the year 2015. He is currently an editor for the Annual of Dentistry of the University of Malaya and the Malaysia Journal of Oral and Maxillofacial Surgery. His research interests are craniofacial anthropometry, variations of the mandibular nerve, and the recovery of peripheral nerves after microvascular repair. He has lectured extensively on dental implants, have started organizing and providing training on dental implantology as part of the University Malaysia Basic Implantology for his oral maxillofacial surgery postgraduate training since 2012. So without further ado, I would like to invite Prof. David Niao to give his lecture, Osstem Solution for Beginners. Prof. Niao, the webinar is yours. Ian, can you hear me? Yeah, Prof. Niao? Okay, they are loading your slides. Prof. Niao, your audio.
I don't know why. I got muted. Okay. Right. Thank you, Dr. Ha, for the lengthy introduction, actually, because I didn't expect that. Next time, I will do a shorter one. For those who are not aware, I was a colleague with Dr. Ha some years ago, but that was a history because he left about 10 years after that. So we have met, we have in different occasions, and finally, this is, I think, the first time he actually is moderating for a talk that I'm doing, right? So I'm very honored to have him, actually. Right, let me see whether things are running, because it seems to be not moving.
Looks good, looks good. So can you click on the next slide, Prof?
No, the next slide is not moving. That's the problem. Just now when you test it, it's moving. Let me try again. Share screen. Okay, can you see this?
I can see the first slide.
Okay, let me see whether it moves or not, because it doesn't seem to move, unfortunately. So I'm going to stop sharing for a while, because it looks okay when you're doing a trial, but then it just give up for some reason that I have no idea.
Can you share without doing slideshow? Don't press the slideshow, just go like normal view when you're doing a slide, what do you call?
Okay, let's try.
The slide.
This is not the slideshow actually, Dr. Ha. Hang on, let me just get this running again. Right, share.
So for the participants just bear with us, okay, we'll try again. Yeah.
Right.
Okay, like this.
Right, let's see whether it works or not. Okay.
Okay. Click next.
No, the problem is now it refused to work.
It
just refused to move.
This is a share screen, right?
Yes, this is the share screen.
Can you share screen like just now without clicking on the... Yes, without clicking on the slideshow, just do the slide one by one, like we are doing our slide.
Let me just start all over again. I think
okay.
It's better that way.
Can you move the cursor one by one and then scroll down?
No, actually my PowerPoint is off already. I don't know why that can appear.
Yeah, then you do like this now.
Right,
yeah, do like this, just one by one.
Is it showing?
This is the first slide. Just now I saw the second slide. You just
is it a second slide?
This is the first. This is second. Yeah.
Okay, good. All right. Finally, something works.
Okay. Yeah.
Anyway, sorry about all the trouble and delay. I am alone. Nobody teach me how to solve the problem because I am not good with this anyway. Right. I put this as 18 reminder. Why? This is after dinner, and I guess if you expect some surgeon telling you some story about implant or any other surgical procedure, it will be a bit gory and bloody and things like that. So maybe you do not want to have your family member listening, or perhaps if you are okay with blood, maybe you want to have dinner with it, but otherwise, I'm just putting up this morning. Okay, so it's my honor to be talking to you today. I know some of you have been attending some courses and things like that, and some of you have seen me around with Osstem implant, basically, right? So the issue is why I use Osstem, I think. So this is a scenario where it's outside my housing area, and somebody put up all the Lorry Sewa advertisement. So for you now is, who am I going to call? Of course, some has a nice number, all right? Some has some numbers that you may not want because it's not a lucky number, but then you don't know the service, you don't know the person, you don't know whether it's good or not. And in fact, when I moved house once, one of my furniture was damaged because it hit a tree and the mover wasn't that good. So those are the issues also you may want to think about when you are doing implant. And then that brings you to the choices that we have. These are some of the lists, okay? It's not complete. They will come and go, some of them. That basically is around. I think I have tried about half of them. And your question remains the same as like my question about getting the transporter. Who are you going to engage? So in this case is for those who are not used to Osstem, for example, you may be wondering why it is one of the choice that we would want to consider. Okay, for your information, dental implant is what we call a Class 2 device, right? A Class 2 device is deemed to have moderate risk. And because of that, they actually do not have a clinical trial. Yeah, so all the study that shows you bone grafting, that shows you longevity, survival, and things like that that you heard about, there is not one study that shows about a clinical trial, just like the vaccine thing. You know, they have done all the clinical trial on vaccine. We're talking about it. We're questioning them and things like that because they're rushing through the clinical trial. But for implant, there isn't. So that makes our choice difficult because it's like even with vaccine, everybody is arguing and saying which is better, which is what I worry and what not, and which is made from where, and you know, people are questioning that. Okay, so it's the same question you may have for your implant. And in this case, there are a few things to look into, whether, for example, you want to use titanium or zirconia, because zirconia has the advantage of being white in color. So if you put an implant and somewhere along the line some bone resorb, maybe it will not look so bad on the patient. So those are one of the options that you have. Other than that, of course, the material, okay, so whether it's a grade 1 to 4 or grade 7 metal, titanium. In this case, Osstem is actually a grade 4, so you can see the strength between a grade 1 and 4, how strong it is. Of course, there are others like what we call a titanium alloy, so they are stronger. The only problem with that is if you see the list here, you see there's aluminium and vanadium. So those may give you some reaction because you want the purest metal, or titanium in this case, to be in contact with bone, and you do not want those mineral or other metal there. Yeah, so the choices depends really on your preference, your research, if you want to call it, what to do. On top of that, there are different design, body shape. If you look at the list here, Osstem has the whole range. You see the TS2, SS2, US2, right? It's like all the different code for some machine gun and things like that. And that actually gives us a bit more option, like what you can see here with a straight implant, for example. Okay, for some people who are used to that as the, what they call it, part of the previous training. And of course, there are those what we call a tissue level implant and bone level implants. So on top of that, even with a taper shape implant, for example, in this case, please be aware that they are different. Okay, so on the left, you can see the non-self-tapping implant. Ankylos, which used to be a system that I used a lot previously in UM. And now we have what we call a self-tapping implant. So basically, the thread of the screw in an implant can find its way into the bone. Let's start by just going through a simple case, okay? A standard implant placement. So this case is actually performed on a patient with a lower molar missing. And the implant that was used is a sort of very famous implant with a tissue level. I think for some of us who actually joined the lecture last week or presentation last week, there was one question about tissue level and bone level. So I'm just going to go through with you a bit about tissue level and bone level in this case. And we're going to start with a so-called the big brother in the tissue level. So in this case, you have a patient with a missing tooth. And here you can see that we use a very simple surgical guide that is opaque in color. The probe is actually just a way for me to locate the center to make sure that the guide was done properly, because the guide is made in the lab. So that is the appearance after we make an incision with the flap raised, and the drilling goes on according to the protocol. And you may want to insert a guide pin. So those are some of the standard procedures that we always do to insert an implant, as you can see here, right? And of course, you note that this is quite a nice case, not bloody, and we ended up with some sort of metal on the top. That metal, the neck of the metal is what we call a tissue level implant. However, in reality, sometimes you want to try and drill 2 osteotomy, 1 and 2, but they are not as easy as what we think due to 1, limitation amount opening, and 2, limitation of site because it's bloody, is filled with saline, as you can see in this image. So those are some of the problem that you will face if you use that implant, the implant I showed you earlier, because the drill is just a one-piece drill. So then, of course, some people will question whether a stopper can help. All right, what if I have an implant drill that will stop me from over drilling? Because the worry, of course, I'm sure everybody will agree with me, is that we are not going to over drill to end up in the ID canal. All right. So those are very real thing. Unfortunately, I have unfortunately caused it. I've seen some other people who are causing it, whether they are beginners, whether they are seasoned people. So we are all having the same risk. It is just a matter of being selective in your treatment planning, and of course in the use of armamentarium. So let's see what we can do with a stopper. All right. In this case, patient has a missing molar, if you notice there. And what we're actually trying to do is to put the drill with a stopper. If you see, somehow I do not know why I cannot put the pointer on the image here, right? I would love to do that. And we have one problem, okay? That stopper actually blocked the surgical guide that we made because we didn't cater for the stopper. So that's one problem that sometimes we do not realize. But the other problem that we realize when you use a stopper, okay, the good thing is it will stop you from drilling further in. You are not going to over drill because there is a piece of metal over here, like you can see here. The only problem, of course, is you are still not seeing the wound or the osteotomy because you can't see anything except the drill, as you can see in this image. Of course, this patient actually has a limited mouth opening. Yeah, and what you're seeing here is just different size of drill being used, but you cannot see them in action. You're just seeing the stopper. So eventually, after all the osteotomy preparation, you can actually end up with placement of an implant, as you can notice here. And after that, on the image on the right, you will notice it is a healing abutment. Right, so we can do implant by drilling without the stopper. That's the normal drill. Of course, you may want to use a stopper, as in this case. But what if you have a built-in drill with a stopper? Okay, and that's what I'm going to show you now with this Osstem implant placement case. A missing lower right 7 molar, okay, on this patient. So after all the planning with CBCT, you more or less can agree with me that we should be able to put in a nice implant without any bone graft. And this is an image that shows the site on the left and the first osteotomy that I've done on the right. Now you notice one thing, I didn't use a guide, right? The problem with COVID nowadays is that we try to limit the number of sessions. We try to limit number of visits. Unfortunately, this patient is a medical colleague, so worse, their time is precious. You know, half the time they're everywhere treating patients, whether they're COVID patient or non-COVID, they're still there. They're still very much needed. So this is a freehand case being done. So you notice I used a guide in the other 2 cases, but not this case, right? So you do the drilling a bit just to mark where you are. I did raise a bit of flap to see better. I always prefer to view because that's part of our training. I know nowadays people go for minimal invasive and you plan everything and you don't need to even raise a flap, you know, that kind of thing. But as for me, I would still be old-fashioned, and that's what happened. All right. So we did the drill hole, which is a bit off, and on the right is actually the use of a drill, okay, to change the position of the first hole. So that is one advantage that you have with Osstem set, because this drill that is called side cut drill allows you to reorientate the first preparation that you've done. As long as the preparation is small, you have the liberty to change it up to 3 millimeter in size. And subsequently, you follow the sequence of drilling, as you can see here, right? There's a yellow drill, there's a green drill, but if you look very hard, there is a stopper on top of it. So there is a shoulder, okay? It's a built-in shoulder that will ensure that I do not over drill. So if you notice that, I'm doing that, drilling in 2 sequence, followed by probing because there's a nerve somewhere down there. And you drill again with another 2 sequence because we were trying to put a 5 millimeter implant into that. Now, this is the Osstem version of tissue level implant. Yeah, and I find it quite a nice system to use. It's quite easy. The drilling and the set is exactly the same as what we will be using for the TS3 tapered implant, which I'm going to show later. But let's finish this case first. All right, so you put in the implant, and you notice a bit of bleeding in this case, but otherwise you can see the whole process. Of course, some photography is bad because this is on the 7th, yeah, right? And you can see once we stop the bleeding, we put the healing abutment, and this is the outcome that you get. And let me just share with you the X-ray basically of the crown. Of course, the crown is a little bit of a disappointment. The color and the shape is a little bit off. But if you look at the X-ray, how the tissue level fits exactly into the, what do you call it, the crown and the neck, okay, they adapt very well, and you will never have a problem of having a gap between the implant and the abutment, as sometimes occurs when we didn't realize that we didn't cement our crown properly. So it should not happen with this tissue level implant that they have. And of course, the surgical guide, the surgical set is the standard set. You can use this for a tissue level, you can use this for a tapered implant. And since I mentioned tapered implant, just have a quick peep at that. You notice it's a screw-like implant with what they call a corkscrew thread and open thread. Now, as I mentioned, they are what we call self-tapping implants. So essentially, if you have prepared it short or less, they may still be able to find its way deeper, provided the bone is soft enough. This is some of the facts that I managed to retrieve from the supplier. So it is what we call a sandblasted aluminum and acid etch implant. All right, and with that, compared to the previous old implant that we used in the 90s or 80s, the branded implant, it gives you an increased time of loading. Yeah, so you can save time, and patient can get their teeth or tooth in faster. Okay, this is how it appears like on your left and right. And you will see the change. The difference on the right is the SA. The left is what we call RBM surface. You can see how rough is the surface, and because of the roughness, it attracts all the osteocytes to grow into the spore-like appearance. And the study that they have shown, comparing the RBM that I've shown you earlier, the SA is the Osstem implant, and the SLA is one very famous product. You notice that the outcome from the SA on the graph on the left shows that it is equally as good, equally as good, and the what do you call this thing? And in certain occasion, like it is actually shows you stronger, what do you call it? Contact. Right, that's the different drill that I've shown you earlier on. On the right is the drill bits that we use without a stopper. On your left is the drill bit that actually is the Osstem implant kit is providing. The only problem with the drill bits that they're provided is that your assistant or your nurse may not really be happy, because they actually have one drill for every size of length and one drill for every diameter. So imagine you have how many pieces of drill in your kit as compared to the simple kit on your right, where you are just doing it according to the marker that is provided. But as I say, the problem is you can't see what you're doing, and sometimes I do find that is a problem. Okay. On top of that, do be aware, all right, there is a difference between the drill size, even though there's a stopper, between the actual drill and the implant size. That's because of the additional drill tip that give you different length, if you can see on the table that's shown here. And what subsequently will happen is something like this. You use the stopper, the shoulder, to stop you from drilling in too deep. But having said that, you essentially may have over drilled. So those are little things for people who are new to this set, new to this system, and is dependent on the whole set to guide you to put in your implant. Okay, so for that reason, because I teach and I work with my residents, and I need to train them up, because one day they will be our specialists all over the country. I always emphasize the need to use a ruler to measure the drill bits, so that before you put the drill into the bone, you know how much you're going to press, how much you're going to try and sink the drill into the bone. It's a bit like doing endodontics, isn't it? Yeah. Okay, let's move on to a different set altogether. All right. Just now, all the set we were talking is about drilling, and now we're going to talk about a set that spread bone, a drill system, but it's not a drill in reality. Okay, it looks like a drill, but it's not a drill. It's called an ESSET kit, which is easy, safe, stable, expanding kit, tapping kit. Is around already. If you look at the year 2002, and now it's 2021, it's been like 21 years. This is how it look like. It gives you a set. You can notice, number one, they have what we call a crystal removal. It just cut away sharp edges of bone. Then they have twist drill. The twist drill is exactly the same drill as what you have seen with the Osstem drill I've shown you. And then they have, number three, they have a saw, all right? So that is for us to split bone, and some people call it ridge splitting. And on the label number 4, you notice they set drill. So they look exactly like the drill that I showed you earlier on, except they are blunt. They're not going to cut, unlike the drill that you've seen earlier. So this is the idea, or the essence, what it's doing. It's preparing an osteotomy site, a cavity to accept the implant, but by spreading the bone, by pushing the bone, by expanding the bone, if you want to call it that way. Okay, and why are we doing that? That's because if you do so, the implant will be in contact, as you can see in the image on the right, with two sides of the bone. Unlike if we are doing what we call a GBR procedure, where part of that implant is actually in contact with that bone that we grafted onto it, and a membrane. So your blood supplies for osseointegration will be very much dependent on the other surface, which is apical, mesial, distal, and lingual, but nothing on the buccal. And the paper that you have seen, that I've cited here, shows is an alternative, and is a good way of working. Let's have a look at the picture or case that we have done. All right, notice this patient has 2 missing premolar. Yeah, and of course, our mission was to try and restore 2 teeth for him. That's how the appearance looked like in the OPG. So standard protocol, as I always do with all my doctors, and in this case, you notice one of our KOL, Dr. Elaine Lim, was working with me on this case. Yeah, so again, you see there's a plastic guide that we made. So that's the easiest thing to tell us where about is the 2 first drill that we're going to make. So after we have done the incision, so in this case, we have done the incision, you raise the flap, you notice there is a little bit of concavity on the 2-4 area. So obviously there is a worry that we may need to do GBR for this patient, right? So let's see what we can achieve without a GBR. Okay, see whether we're doing well. So the first drill is the lens drill to mark where the hole is. So there are 2 drills to do that. And after that, we put a pin exactly like the same first case that we did that show where we put a marker pin to show you where about is the position of the implant. Okay, so we can use a side cut drill and change the orientation if it's wrong. It's still early. And in this case, you can see there's a saw in action on the right side. Actually, when you do the cutting with a saw, your handpiece is facing outward, not on the palatal, all right? So in this case, that is just for illustration purpose. If I'm putting that handpiece facing, I mean, from the buccal, the saw will not be visible. So what we do, we cut that with the saw. There are 2 sides, right? And from the same osteotomy hole, we can put the ESSET kit, as you can notice here, to expand, right? The osteotomy that we have done. And they actually come with a different color code, and you can see a yellow color coded kit, you want to call it a drill, right? But they're not cutting. And again, we can sort of double check everything with the pin before putting in the implants. As you see here, we have 2 implants. You can check the occlusion. You may notice that I have a mount here, right? You had a mount I showed in the case of the tissue level implant earlier on. And in this case, there's another 2 mount. And I found that quite useful because they will actually give you an idea where your implant is going to be like in relationship to the upper teeth in this case and the lower teeth as well. Yeah, so following that, if you look very hard on the buccal side, there is still no fenestration or adhesions. So we finish it off with adjusting the implant, all right, with the top range and closing up the side. So that's the eventual outcome that we have. So that's one way of doing implant without GBR. You can actually use the ESSET kit. And I find this is one product that's quite good, that is quite handy, and in a way it kind of make life easy because that kit, the drill, that is the blunt, is not going to cut any bone away. So we're preserving bone altogether. Let's have a look at another case we're doing similarly, but it's a bit like a condensation like, okay? So the saw is not in action in this case. So you notice there's a root treated tooth that fractured, that is non-salvageable. We took out the tooth. You see there's something whitish there because we grafted it with a material that Osstem carries, but I'm not going to talk about them. We'll let the other KOL mention to you or give you know, more detailed lecture eventually. So in this case, you have a missing tooth, same rule with a surgical guide. Of course, you will find that my quality of surgical guide differs. Sometimes they look nicer, sometimes they look not so nice because they were all done by different people. Yeah, and unfortunately for them, it's part of their so-called training because I would like them to put the implant as accurate as possible, as good as possible in relation to the occlusion. So in this case, I always use a probe. You notice that to mark, to have an idea. If you take away the guide, you know where you are. Because when they prepare the guide, the problem is we do not use CBCT in this case, and they actually did it on the model. The model, unfortunately, is not that accurate because there's soft tissue overlying it. And in this case, we were just checking to ensure that it's correct. You raise a flap, right? You double check. And subsequently, you start drilling similar to all the other sequence that I've shown you. And you notice that if you drill slow enough, you may even collect bone, as you can see in this case. And you notice there is a shoulder on this implant, right? And those shoulders, if you can use it properly, it will ensure that we are not going into the sinus. I'll show you the image eventually after we've done it and see how close we are to the sinus. But if you can see here and you can appreciate, I always try to make sure the first drill or so, or the second at least, we try and get it as accurate as possible, because after that, there's not much room for improvement. Okay, so you see the occlusion, you see the drill hole, and we did enlarge it a little bit. Yeah, and the ESSET kit comes into action, because if you notice, it is now the non-cutting drill that is in use. And subsequently, a blue color, and that is 4.5 diameter. Okay, so you put in the implant, you check the occlusion again, right? You uncover everything, you put a healing abutment, and this is what we can get with the ESSET. Of course, the ESSET is good in this case as well, because it's blunt, so you're not going to cut into the floor of the sinus. If you can see from here, that implant actually seems to touch the floor of the sinus. Okay, so we actually have do a lot of cases using handmade, okay, or self-made surgical guide, but then we can't ignore the technology that comes in. All right, digital implantology. So Osstem is one of the provider now. They have the whole range. You see here is one guide, and with that one guide, you have another set of kits to use together, right? Complete for every single implant that you're going to put, exactly like a tapered kit, except that you find now the stopper or the shoulder is huge, right? So you have the difference in the drill stopper side, whereas the rest, the taper drill, is similar as the previous tapered kit that you've seen. So all drill, they are custom made for this Osstem guide, okay? And if you look at the last sentence, it will give you an idea of the difference of the tip length of the drill, yeah, so that we're not going to over drill when we plan surgery in these cases. And of course, we have to look at the extra 10 millimeter of length on the installation. Just double check. I hope I'm not offline, yeah? Okay, so let's have a look at another case, right? You can see this patient has quite a number of missing teeth, and you will notice that there is a premolar with a lesion. Okay, that tooth eventually got treated. Yeah, so we just don't do implant without treating other teeth. And if you can see from here, right, that's how the appearance is like. This now is a case that we're using surgical guide called One Guide Kit from Osstem. Now you notice on the image on your right, there's a little bit of prick point there, okay? And those are actually infiltration, site of infiltration that was given. So, excuse me. So the question will be whether you need to do a block or you do infiltration. So in this case, you notice that we did infiltration. The previous case that was done on the tissue level implant was done using a block. So, I mean, to me, it actually do not differ much. My experience showed that if a block and you go and cut a nerve or drill into a nerve, patient will still tell you that it hurts. So maybe they hurt a bit less compared to infiltration. So other than that, to me, the anesthesia, what we want is the patient has a pain-free procedure, as you can see in this case. So in this case, we raise a flap. We did anticipate the buccal side of the 4-5 area will be a bit deficient of bone based on the CBCT planning. So I'm just going to concentrate a little more on the right side. Okay, you see there are the One Guide Kit, which is a bit bulkier than the one that we make ourselves. But of course, in this case, we're doing bilaterally. So definitely it will be bulkier because we need to really sit it properly onto the dentition to ensure the free end do not move when we press it with all the drill bits. So that's the drill kit that is been in action. You can notice the difference in color, right? See a yellow, green. And now the difference in the carrier, you notice we have two things. One, the implant that we are using do not have mounts. Two, the implant carrier has a bit of unusual shape, okay, unlike the one that I've shown you earlier. And the reason is because it is supposed to fit into the guide, to follow the guide, as you can see here, to ensure that it goes in properly. We can use the top guide as well. And if you notice, all of them have a similar design to fit the one guide system. So you just keep on doing the same thing again for one preparation, subsequent preparation, and at the end we get all the preparation done. And as I said, there's a little bit of bone deficiency on the buccal of the 5, which we grafted with a bit of bone graft, and we'll close it. So the same things happen on the left side, and at the end you see that it's quite clean procedure. We can actually do it on the same time with 5 different implants being placed with minimal flap being raised. And this is one side of it. Subsequently, this is how it appears post-op, and this is how the patient appears to be like after a year. Well, this is a year because of COVID. Okay, clinic closed, patient cannot travel and all these things. So you can notice that how much the one guide can actually ensure that you can put the implant nicely, as you can see in this case, with proper alignment. How about a cheaper guide? This guide system is good, but there are 2 issues. One, you need a CBCT to plan it. 2, you will need to pay for that system. Okay, so of course, it's a bit of a problem for us in because sometimes patients are not from the higher income group and they do have issues with it. So there are other guides kit that you can use. This is what they call a parallel guide kit. You can Google and search it out. All right, and what basically you can do is you can use it for single tooth, multiple teeth, and even posterior. Means that not posterior, sorry, edentulous, fully edentulous tooth. So what is the difference in this case? Let's have a look at this case. Okay, so that is a patient with missing premolar, even though it looks like molar. Okay. The size of it is a molar size. So in this case, we can use a surgical guide that, as I keep showing, we prepare ourselves, or you can use this parallel guide kit. Okay, so if you look at that, that's the preparation. That's basically how it will fit into that. There are multiple sizes. You have to find the closest size to use, and the beauty of this is it's fairly simple thing to use for a single tooth, like in this case. On top of that, there is another guide kit called Smart Guide Kit. All right, so it's made of medical grade thermoplastic material. It's become flexible when you put it in water that's quite warm. It's about 70 degrees, and it will harden in room temperature. Unfortunately, it comes with a kit, so you need this kit to use along with the Smart Guide. Yeah, you need the special drill, and that's the sort of a flyer showing you how it's done. But instead of trying to show you on the flyer, which is rather small, I'm going to show you on this model where we have missing tooth. Okay, and we are planning for a tooth replacement using implant. So what you're doing is you actually prepare the guide on the model. So the beauty of this model is you can draw, you can mark, you can look at it from the side, you can draw the axis, and you can erase it if you want to call it, yeah, and redo it before you drill a hole. As you can see on the image on the left, we drill a hole. On the right, we double check the positioning. So the only problem that I find with this is sometimes when you drill the hole and it's a little bit too large, it wobbles a bit. Okay, so if you see on the image on the right, we put a bit of sticky wax, try to hold it so that the pin do not move, and now you have a stable pin, and some of the sticky wax is actually used to block the undercut. And this is what the Smart Guide look like in hot water. Before on your left and right, after it has changed transparent. So you put it into the hole, through the hole, and over the other supporting teeth, and let it harden. All right, so this is a fairly simple guide, fairly easy to use. Of course, it's less hassle than trying to do the surgical template kit that my residents has been doing, as you can see here, right? So let's see how it works in the mouth. So that's basically how it is like once we place it over the oral cavity. It should snug in nicely, right? I did make a small hole as I usually make, just to mark and see where am I. Then raise a flap. In this case, you notice the flap is what we call papilla sparing incision. We do not go to the adjacent of the molar. And you use the drill again. You use the drill that has been in the set that I showed you, and subsequent drill that is in your kit. In this case, we actually use a stopper. All right, I'm going back to a stopper now because I started with a drill without stopper, then I show you a system with a stopper, but now in this case, I'm using a stopper. Now, why am I using a stopper? That's because there's a sinus over this molar area. So in this case, we use a drill, a special drill with a stopper. There's a special probe with a stopper, and we keep enlarging it. You notice there is always the stopper and the probing, and the stopper and the probing, multiple sequence. And you notice we can even collect some bone if we do it properly, not overly too fast in this case, right? So this is a smart guide being used at the initial, but we actually end up using a different sort of system to put in an implant. Okay, so after all the subsequent drilling, you end up with the Osstem implant being placed in the molar, and that's how it appears to be like in relationship to the sinus. Now you notice like the floor of the sinus has been like elevated up. Yes, indeed it is. And the system that can do it is this crystal approach surgical kit, or what we call a CAS Kit. So now you may get a bit more confused because we have so many kits, so many things to use. But like I say, that's the beauty, because they have everything to cater for your need. And I find it's a very good thing to do, especially if I'm training my resident, because they will, one, get the benefit of a different way of doing things. Yeah. And in this case, we use this surgical approach kit, which I'm not going to talk much. All right. I'll leave the other KOL give you a nice lecture eventually. But essentially, what is the interesting thing about this kit is the stopper and the special drill. You notice that drill with what they call inverse conical drill tip that can be safely drilled until the floor of the sinus, as you can see on the image. So the stopper will allow us to keep drilling 1 millimeter, 1 millimeter, millimeter by millimeter less. There is another system available in Malaysia with a stopper, with something like this kind of drill, but it's made of a different material. The only difference with the system is that the differences between both stoppers, all the stoppers are 2 millimeters. So it's kind of a bit aggressive. To me, 1 millimeter would be good, would be safer, and it's good for my trainee, basically. Yeah, right? Maybe you can appreciate that as well. Then this is something that is useful. It's very unique. We call it a hydraulic lift system, where you can actually use the saline to lift up the floor of the sinus. So what's the outcome? Sharing with you 4 different types of floor elevation. On the left top, you see osteotome is one that is using the old Summers technique. On the right is by the use of osteodensification burr. Some of you may have heard about it, a burr that can lift the floor of the sinus. Of course, the case that I shown you is one that is cast hydraulic alone, and then on the right is actually cast with bone graft. You may not be able to appreciate too much on the right, lower right image, but actually there is some bone being placed there, but the radiography do not show as clear as you wish. But anyway, it's not a problem, because we know that we can even let the implant touch the sinus membrane without any bone. Okay, so basically I've covered most about the tissue level, tapered implant, and the different way we can insert implant. I'm going to move on to something that a lot of people hear about. Some of you may be using it. Okay, we call it mini implant, but then for Osstem, they do not call it implant, mini implant. They actually call it MS implant. Okay, so we people may get a bit confused between the mini and the MS in this case, but essentially, Osstem has a whole range as well. So in this case, we have MS implant. Mini implant in Osstem is used as a two-piece implant. So in this case, MS implant is what we call a narrow one-piece fixture. This is a patient with a missing C. You notice the site is very small. Okay, it's difficult to put a standard size implant. And in this case, we're actually going to put an MS implant. Yeah, and you notice a little bit of a difference between the image that I've shown you earlier than this one, that there is some floss threading around the lateral incisor and the premolar. The reason is I'm just trying to box around the area. We just want to put a ring around the area. Of course, you see my standard surgical guide keep coming in again. And in this case, the drill is in the center, it's within the boundary. It's like you're in boxing or wrestling, right? You cannot run out, not like WWF boxing and you can run everywhere. So, I mean, wrestling, you can run everywhere. So in this case, your implant is going to be within the range, within the floss that is placed there. So in this case, we put the pin, we can check the occlusion. The only problem with MS implant is you only have about 2 chances of drilling and that's it. So it's a bit tricky. Don't mess it because you can't change the angulation orientation like what I've shown with the regular implant. Okay, so with that, we managed to put in an implant. And you notice I have a different type of suture then. This is a nylon suture. And that was the time when there's some luxury of nylon. We gave the patient a temporary crown, and the image on the right is actually the real crown. This lab actually did a very good job. Okay, I think you will agree with me. You don't even realize that that is an implant tooth. Okay, this is one of the best crown that I'm very happy to show people because this is really, really nice crown. Okay, a little bit about MS implant. All right, it's for narrow ridge, small one-piece implant. Apparently, you can bend it a bit, but I actually dare not do that. Yeah. All right. If you look at the last sentence, it said the direction of implant can be corrected during incision. You can change it a little bit, but no, I'm not going to do that. I'm not going to adjust and weaken the implant and things like that. So I'm going to end with this case, a different use of MS implant, as you can see in this patient, with a long span bridge. And if you look at the CBCT, it's like the bridge is like hanging there because there's no bone. Okay, so under LA, we can easily just pull the whole bridge off because it's just stuck by soft tissue. Okay, so when you raise a flap, you notice there's a lot of bone loss, a lot of tissues, and what do you call this thing? There are not many areas where we can put the mini implant. If you notice here, we actually managed to find some bone nearer to the premolar area on the right and a little bit on the left. So 1 pin, 2 pins, 2 drill. The mini or MS implant is in, and you notice that the head is now different. The head that you saw earlier is a flat head. Okay, in this case, it's a round little end there, which is supposed to be able to accept O-rings for denture support. Okay, so the implant goes in. You do the same on the other side. We managed to do it on 1 area on the left instead of 2. And we grafted the whole area with whatever bone graft that we have at that point of time. And that's how it appears like after we put the cap for the denture and put in the denture for this patient so that he will go back with a prosthesis. So this is not the best case, I have to admit that, right? There's a lot of trouble trying to do this case because this patient is outstation, not staying in Klang Valley, all the COVID's happening, but that at least I can share with you some cases, because I'm sure there are people who ask about what we can do for people with denture, right? Do we convert the denture to more higher end regular implant supported, fixed or removable prosthesis, or can we do something like this, right? So a word about this, right? So basically the micro thread on the upper part distributing the chewing pressure, okay, throughout the bone. Well, that is what they claim, all right? I am not able to verify that because the number of cases that I've done is really, really very few. And this is one of the few cases that I just want to share more, because I want to show you the range of implant product that you can have, you can do, you can use, and you do not need to worry about getting different material or different drill, different size, different implant from different supplier, right? So I'm going to end here with this thing, okay? That is my personal opinion. I have to put a disclaimer that because of my association with them, right? And this association is official. It is something that we've gone through the university, and they have been supporting us for many, many years in my residence training. And as I say, they have a wide range of solution, okay? I find that's very good. That is very useful because I do not need to worry about getting different parts from different supplier, as I mentioned earlier. Two, because of my job as a trainer, it's just like your job if you're, a driving school teacher, you may want to have an emergency brake on your side in case your student is going too fast, too slow, skidded, things like that, okay? And similarly, what I found about this stopper that Osstem has is quite reliable, so my resident will not over drill. And of course, sometimes they go sideways and things like that. But having said that, there is mechanism to try and correct it to the best that we can, and eventually be successful in placing the implant to the best occlusion that you can achieve. Okay, with that, I think we're just nice 1 hour. I'm going to end with this. I'm not sure whether you've seen this. Somebody shared this somewhere in the social media, right? If you put something like free implant, free cure, free vaccine, everybody will take a strip of that. Having said that, unfortunately, it's not the reality. We are still not out of our pandemic. In fact, I'm in Klang Valley, so it's like we are getting from bad to worse, the kind of thing. And we are just hopeful that things will get a little bit better by over the next few months. Not to say a bit, but then gradually, I will say that. Okay, so I thank you for your attention. So I return the floor to Dr. Ha, and I'm going to exit the, what do you call this thing? Screen sharing, yeah?
For very interesting lecture to cover a variety of clinical cases that can be done using the Osstem implant. I think Osstem implant is one of the one-stop center for implant dentistry. So Ian, can you have the question coming? So while waiting for Ian, so maybe I can ask Prof one questions. Between the tissue level implant and bone level implant, so what do you think of that?
Okay, I have actually done most of my implant, I think 90% with bone level implant. Okay, I've done some tissue level implant of the different system. The thing with this tissue level with Osstem, for some strange reason, they didn't introduce to me much until the last 2 years, right? So I'm a late comer, I would say, to the tissue level. So tissue level has its challenge in this case. I realized that. I just had one case that was sent to the lab, and they told me that the because it's a tissue level, because certain angulation, because sometimes you don't put the implant vertically straight, you tilt it a little bit to follow the occlusion and things like that. They told me that I need to use a standard abutment for the crown, and so you cannot cam it in a way. So those are little things that we learn by experience. Having said that, I won't say it's a disadvantage, but it's something that we have to be mindful about. Otherwise, I mean, I'm a new person with that. I find it's quite useful. I find it's very good in a sense. There is no gap between the abutment and the implant fixture body, which is what the other brand with tissue level is doing. And these designs allow you the same. In fact, the difference with this tissue level implant from Osstem, okay, I mean, we're not saying that we're trying to promote it, is that the body is tapered. Whereas the other system that we have in Malaysia is actually a cylindrical. So in a way, I mean, if you have seen the cases I'm shown and things like that, tapered implant has some flexibility. I always remind my residents, they have some flexibility because it's self-threading. It can cut a little bit. So even if your angulation or your tap is a little bit off, you can adjust a little bit with the implant body itself. You unfortunately cannot do that with a cylindrical implant. So I think that's the plus point about the Osstem tissue level implant.
Question number 2, implant supported overdenture can only be done with MS implant, or is the ball head available for regular implant as well?
Okay, I regret showing that because we follow the protocol. So we did not have a ball head like what you suggested. I know there is other system where you actually do the mini implant and then you just use the ball head with the O-ring. So this one is not. This one is we're actually following the full system of Osstem. So I cannot answer you more than that, unfortunately, because of my limited experience. It's not fair to say something that is out. Yeah, please contact to the company if you're really interested to use it, because I mean there's always the support, the cost, and what range they can provide you in this case. Yeah, so that you get the best. The problem is last year was bad. It was COVID. You know, sometimes we want to get supply. The supply didn't come in from overseas and things like that. There are companies who are a bit slower. They are maybe a bit more faster back to service and things like that. So at that point, this is one of the reasons why we ended up with this system. I did inquire about different brand, different system, different length, different diameter, and things like that. In fact, I want a long implant because this patient actually has a lot of bone loss, and I want to make sure that this implant is sinking as deep as I can. So, and in this case, we found Osstem is able to provide that. Okay. How
about the regular implant? Do they have the locator?
Yes, they have. The regular implant has locator. We can do all the usual stuff with denture, with locator using Osstem implant. There is, I mean, there's a connector to it and all those things. Like I say, I can't be showing everything in 1 hour, and it's only where other KOL show all the locator, sinus graph, and all those things in the future. Yeah.
Yes. Very good. Yeah. Any more questions? Is Parker infiltration injection good enough to numb the patients when placing implant for lower posteriority?
Okay, I hope Parker means including lingual. I mean, the thing is, there are 2 blood nerve supply, right? So if you just talk about Parker infiltration, posterior teeth, lower, no, it's not good enough. If you talk about Parker infiltration, posterior for upper, maybe you can just give one without jabbing the palatal, and you find the patient is numb enough because the bone is porous enough. Okay, so yes, you can actually put implant with just infiltration, but definitely in this case, I'm talking about Parker and lingual. I think Parker alone is not adequate. We know there is this LA called Articaine where it's used as an infiltration. You are not encouraged or advised to use it as a block. Yeah. And Articaine has the best bone penetration as LA. So it actually gives you a very deep, profound numbness. And it's actually a very good implant in this case if you want to use it as infiltration, because there are different types that we use, and I find some are not as good even as infiltration for normal extraction, which we have unfortunately bought for the university. So just be mindful about that. Yeah.
I think Prof, the question is that for lower posterior, do we always need to do a block, or can we just use infiltration to complete the surgery for lower posterior?
Okay, I think, all right, let me put it in summary. If you go to all the implant course and lecture, they tell you they always give infiltration. So if possible, stick to that first. If your infiltration do not work well, maybe you want to add a bit of block. I mean, like I say, I do block all the time. Yeah, doesn't mean that you should follow me, right? It's not fair to say nothing will happen, and then because somebody says that you can do it. Okay. To me, as I said earlier in the lecture, both infiltration and block works equally, meaning that if you drill into a nerve, whether the patient is under infiltration or block, they will jump. Okay, I've seen enough, I've done enough. So don't think that if you have given a block, patient will not feel pain. That is a very simple way of understanding. Similarly, we always get the idea that if we injure the nerve, patient will get numb. It's not all the time they're getting numb. They can cause all sort of sensation. That is unusual. So that is the thing that we have to be mindful about.
Okay, next question, Ian. Suppose your implant is misaligned. To what extent can you customize abutment fit the future prosthetic angle?
Oh gosh, I'm getting more and more difficult question now.
Yeah,
because
you
I'm not a prosthodontic guy,
want,
okay? So I can misalign the implant and dump it to the prosthodontic people. No, I'm just joking. No, there is a guide. Every system will tell you how much. Normally it's about 15-25. Now the latest I saw, there's one promo that can go about 40. Yeah, but having said that, don't do it if you can avoid it, because if it's in the anterior, is aesthetically challenging. In the posterior, even you can correct it with the abutment. You have to think your abutment now is 25 degree tilted, and it's taking the load every day. So eventually it will fracture. Okay, so I cannot answer you the detail. I'm sorry about that, because I do not do the postal parts. Okay, I have colleagues who do it, and I just do most of the work on the surgical aspect. And do be mindful that every system has different what we call angle of compromise that they can allow. So we have to go by what they recommend. Is this, you can't say I go to this course, it tells you 30 degree max and that's it, because that's dangerous.
I think, Prof, the first thing we want to know is that if you do a customized abutment, I think you can go any degree that you want. But the first thing we want is to place the implant in the correct 3D positions according to prosthetic driven protocol. But sometimes, because we are human, so once the implant is misaligned, then how much can you correct? For a cement retain, most probably you can do away with
We can.
But if you want to do a screw retain, then you might look at into the abutment, screw abutment that come with the system. You can use the multi-unit abutment to correct the angle, or you can use now the angle screw channel, or the third party, what they call dynamic screw, or now there is a company that can cam the position for you, which is called true abutment. So all these are prosthetic means that you can do for a misaligned implant. But having said that, the best thing is to plan your implant well, execute it well, put it in a proper 3D positions. Okay. Any more questions, Ian? why is there an extra 1 millimeter length on the drill with stoppers?
I don't know. That you have to ask the Korean manufacturer. But I mean, why I'm highlighting is to alert people who are not used to the system, because if you go by the normal marker system with a simple implant without stopper, we can sort of follow the line. Okay. The only problem with following the line is it's not visible at the 7 sometimes, or it's difficult to see. Or it worse if your patient cannot open the mouth big and things like that. So in this case, I don't know. I honestly don't know why they actually want to make the stopper 1 mm different. But to me, it's an advantage to me. All right, it's an advantage to me because I can actually drill 1 mm deeper. So if I'm putting a 10 millimeter implant, I actually use a 8.5 millimeter length drill for my resident. Because if they over drill, they're going to be 9.5, 10 the most. They're not going to over drill. Whereas if I let them use a 10 millimeter for the training, and they can't see the line because there's a shoulder there, there's a stopper there, they will actually press it too hard, and before you realize, because the problem with drilling thing is you press, you go, and that's it, right? You can't reverse the damage after that. And I can't just carry on doing it myself. I need to, you guys have gone through the training for dentistry and all this thing. You will have to do it yourself to have a feel of it. Maybe not the whole surgery, for example, but then you still need to do it. So I actually make use of that extra as to my advantage. As long as you know the system well, you understand it, you can actually use that 1 mm extra. So maybe the supplier will be able to answer you better once they get in touch with you.
I think they call it the wide dimensions of the drill and the implant, because the design of the implant, if it is flat at the apical part, the drill has to be tapered for cutting. So that tapered part must actually is the extra 1 millimeter on the design of the drill. And most of us, we know if it is not type 1 bone, and with the most of the self-tapping implant now, you do not need to drill to the actual length, because once you tap it in, or you use your top wrench, it will go into the depth that you want.
True.
It's a key point when you under drill instead of over drill.
Good question, actually. Never thought about that.
Okay, next question, Ian.
End of session.
Very good. So it means Prof has given a very clear lecture today. So having said that, so Osstem actually has a wide range of implant, from the parallel implant to tapered implant to bone level implant, a tissue level implant, a one-piece implant, and their mini implants. So, and they have their bone graft, and they are going to launch another new surface later. So stay tuned with Osstem Malaysia. So final words from you, Prof.
No, I think keep on doing implant. I guess everybody has to do it, because not because we're promoting this brand or that brand or whatever, but that is the future, right? Until somebody can start growing teeth, we have to replace teeth. And this is to me, is a good alternative to crown and bridges, because I think we have been seeing some crown and bridges. I've seen some of the crown bridges I've done long time ago that is now start to fall apart. Okay, so beside that, keep safe, everybody.
Okay. So thank you very much, Prof, for a very excellent lecture. So we will sign up for today. So, and thank you to more webinar from Osstem Malaysia. Thank you, everyone. Good night.
Night.
Ian?